Welcome to this presentation about COPD and multimorbidity. My name is Bjorn Stallberg. I'm a GP in Sweden and researcher at University of Uppsala. And you, Kristian?
My name is Kristian Jensen. I'm a GP in Denmark. We will present a case for you of a COPD patient mistreated as asthma.
And we will also discuss a lot of things about multimorbidity in COPD patients and what it means for those patients, and also how we can improve the management of these patients and how we together can do it better.
Up to 80% of patients with COPD will have at least one comorbid condition. Half of them will have 3 or more. For the GP, the multimorbidity tends to blur the picture and make it difficult to make the right diagnosis and to keep track on the regular follow-up visits.
Here we have listed some of the most common comorbidities in patients with COPD. We all know that cardiovascular diseases like heart failure, ischemic heart disease, hypertension, osteoporosis, anxiety and depression, diabetes, and don't forget lung cancer.
According to Gold 2020, multimorbidity should not delay treatment of COPD, and comorbidities should be managed according to usual standards. So keep treatment simple and minimize polypharmacy. Therefore, carefully evaluate the indication before initiating ICS treatment. If the patient has comorbidities as diabetes, osteoporosis, or pneumonias, you should consider withdrawal of ICS.
Now we will present a case study, a patient, to discuss how we could identify and also manage the multimorbidity of people with COPD. And now the patient.
Yeah, this case is based on one of my patients from my own clinic. It's a 65-year-old male, allergic rhinitis up to the age of 35 years. He retired 2 years ago. He has worked as a paramedic for 30 years. He runs a mechanic shop for garden machines in his spare time. And he likes traveling with his wife on vacations with their caravan. No sports or exercise in his free time. He has a history of hypertension for many years. Myocardial infarction for 10 years ago. Osteoarthritis leading to a knee prosthesis 5 years ago. His current medication is amlodipine, acetylic salicylic acid, and atorvastatin. Obese in his 30s, weight 108 kilograms, height 168 centimeters, and a BMI on 38. Despite his medical history, he has very limited contact with primary care over the years.
And of course, the patient have a respiratory history too. He has been smoking 40 years, 40 pack years, but he stopped last year. That was great. And the patient, he believes he's suffering from asthma. The diagnosis have never been verified with a spirometry examination. 10 years ago, he was prescribed with a fixed combination of ICS, inhaled corticosteroids, and LABA, formoterol, twice daily, and also short-acting beta-2 as needed. And he still has the same medication, ICS LABA. But according to the records, he has never been prescribed any oral steroids. He hasn't been to any asthma checkup for the last 5 years. Very interesting. And how does he get his asthma prescriptions? Yes, he usually renews the prescriptions when he has been to the GP clinic for other reasons than asthma, sometimes just by a telephone contact. And when we looked in the record, the last 10 years, he has had at least 6 episodes with a diagnosis of pneumonia treated with antibiotics, but no one the last 1.5 years.
Now he has a scheduled visit for a general medical examination and blood pressure control. When asked, he admits symptoms with dyspnea and breathlessness when walking fast or uphill. He has no cough pain when walking, and he also has morning cough and cough when he's exercising or laughing. He had no exacerbations in the previous year. Heart and pulmonary auscultations is without remarks, and his blood pressure is 145/85.
And this time, he also agreed to perform a spirometry examination. That was the first ever. And on the next slide, we will see the results. And here we have the result with FVC, 75% are predicted after bronchodilation. FEV1, 54% are predicted after bronchodilation. And the FEV1 FVC, 0.56, and reversibility was just 5%. And we will come back to this a bit later. But first we take next slide.
So take a minute to reflect on this information. What is the most likely diagnosis? Is it asthma? Is it COPD? Is it both asthma and COPD? Or is it heart failure? What do we need for more information or investigations? What would you suggest? Take a minute to reflect on that. Results from questionnaire, more questionnaires, CAT or CCQ, chest X-ray, CT scan, allergy testing, blood eosinophils, or pro-BNP measurement, ECG.
Some results. The CAT score was 15. And you know there is a limit of 10 when it's high or low symptoms. As he had some coughing and more dyspnea, we also performed an X-ray with nothing remarkable. I don't think there is an indication for CT, so it was not done. Allergy testing, no, it was not done. But to measure the blood eosinophils count, that could be good, could be nice, and of great value. The result was 200 cells or 0.2. And as he had a history of heart disease, we also did a BNP measurement. It's a blood sample for screening of heart failure, but the value was normal. So we had no suspicion of heart failure as a reason of the symptoms of breathlessness. and the ECG was normal.
So what is your assessment now? What do you say, Bjorn? Next.
I think we have to go back to the spirometry measurement. And when we look at the result from the spirometry, the gray numbers is before bronchodilation, the green numbers is after. And you can see here the ratio FEV1, FVC was 0.56 after bronchodilation. And of course, the patient don't have asthma, he has COPD. And the FEV1 was 54% of predicted after bronchodilation. And, you know, we can classify the patient according to the spirometric severity. That, so this patient is going to moderate severity. And there were no significant reversibility, 5%, very low, 90 mil. So the diagnosis was from now changed from asthma to COPD.
So just take a minute and reflect on these questions. Should the medical treatment be changed after the revision of the diagnosis? If changing therapy, what are the reasons to change? Which treatment should be recommended in the future? And how and when should the patient be followed up in the future? The question is, should the medical treatment be changed now? Until the change of diagnosis from asthma to COPD, his medication was a combination of ICS budesonide and LABA formoterol, twice daily.
I think the treatment should be changed. And what is the reasons? What are the reasons? The patient has no signs of asthma. He has a history of pneumonia, and we know ICS increases the risk of pneumonia. The blood eosinophil counts was 0.2, below the level 0.3, so the indication for ICS is really low. And the CAT score was 15, and no, as we can see, history of exacerbations last year. So the patient is classified as Gold B. So now we have to think what treatment should be recommended. If you look at the guidelines, there are several options. You can give LAMA, LABA, or a combination LAMA and LABA. And of course, I think the GPs will do different here, and some it's just okay to start with LAMA or LABA. But I think I had preferred to give a combination LAMA-LABA, as he had a lot of symptoms. The lung function was quite low. That's my preference.
And now when the patient is here at the clinic, we will use the opportunity to make a decent follow-up for the future. And that follow-up might include a referral to a physiotherapist, a checkup on the inhalation technique, and a follow-up with the new cat at the primary healthcare center after 2 or 3 months. It all depends on your opportunities in your practice. So reflect on that for a minute. What are your opportunities to follow this kind of patient up? So to summarize this case, a correct diagnosis needs a spirometry test with reversibility test.
Yes, and of course, we have to evaluate the comorbidities. I think that's really important.
Absolutely important, yeah. And you should consider risk and benefits with the pharmacological treatments.
Yes, and the follow-up. And as you said, check the inhalation technique. I think that's very important. And also a referral for physiotherapist. So the follow-up is really important.
So what is your conclusion from this case? Thank you.